All right. Welcome, everyone. I know a few people are still joining, but I think we can get started. My name is Alison Hamilton. I lead the UCLA Rapid, Rigorous, Relevant Implementation Science Hub, which is a supplement to CHIPS. We are always very excited to host these beachside chats, and today is definitely no exception. I'm so excited for today's talk. And I know many of you have reached out to me in advance of today's chat saying how excited you are for the topic. So I have a feeling our incredible panelists will have many, many excellent questions to field as we proceed with our chat today. So for anyone who has not been in attendance at a beachside chat in the past, these are really meant to be times for informal discussion, conversation, kind of grappling with issues in implementation science. And our panelists have a wonderful topic of great relevance to our hub and to the ending the HIV epidemic related to equity grounded implementation science. They're doing some amazing groundbreaking work in this area, building on the work of many others who've been putting forth work in this area. And I personally am very, very thrilled to welcome my longtime colleague, Dr. Leo Cabassa, as well as Dr. Nagy and Dr. Rivera-Segarra. So thank you so much to the three of you for taking time to be here today. Apologies for my scratchy voice on the recording. It is what it is these days with everyone getting a little under the weather, but very excited nonetheless. And I think that I will hand it over to the three of you to get us started. We're going to have a brief presentation overview, and then we're going to open it up for discussion. So I'm going to hand it over to you. Thank you so much.
Thank you, Alison and Elena and the group at UCLA for this invitation. We're very excited to present this. This is the first time, actually, I think we're presenting in a presentation. We did a poster in the D&I conference, so it's excited to see this work move forward. My name is Leopoldo Cabassa. I'm a professor at the Brown School, and I'll have the other two speakers introduce themselves as we're beginning to share some slides. So, yeah, go ahead,
Yeah,
guys.
thank you. Thank you so much for having us. My name is Gabriela Nagy. I'm an assistant professor in the Department of Psychology at the University of Wisconsin-Milwaukee.
Hola, everyone. My name is Eliut Rivera-Segarra, and I'm an associate professor at the Ponce Health Sciences University in Puerto Rico.
So Gabi's we're gonna share some slides just to provide some context of the talk, and then we'll take some questions and discussion as we're putting this together. And I want to make sure we have it perfect. So this paper actually comes about both Gabi and Eliut are former RRI fellows, and I had the privilege of being their mentor 3 years ago. It feels like a long time ago, but it hasn't. And it was a great opportunity to put some thoughts together around this particular topic and actually develop a presentation and a publication that is forthcoming, hopefully in a special issue in psychological services in the next couple of months. So we're excited about this work. So just to set the stage, why do we need an integration of health equity and implementation science? There's many different reasons for that, but four main components that we saw and that we're making a sort of a case for this is, first of all, inequities in health and healthcare continue to increase, and the importance of translating evidence into practice is taking longer in minoritized communities, particularly in the United States. And I do want to preface that a lot of the work that we're going to be talking about today and the examples that we're presenting are all based on US-based studies, either in the mainland United States or in the territory of Puerto Rico. There's also a need to move beyond documenting and eradicating inequities. Implementation science offers a pathway for those solutions. There's a lot of work on documenting and understanding those inequities, but the real field is really moving forward and trying to find ways of eradicating those inequities. A lot of implementation science, and you will see shortly some analysis that we've done, have argued for an increase in the focus of inequities. And similarly, from health inequity research, they have noted the importance of focusing on scaling up and sustaining intervention. So we see these two worlds actually really addressing a particular issue of how to address this and coming at it from different perspectives. we have seen sort of an increase in the number of calls to action to date, and these have been great papers. We have used those papers, we've learned from them, and a lot of them, however, have been largely aspirational or theoretical. Given that we're in a implementation science audience and everyone has a theoretical framework, God knows we don't need any more theoretical frameworks. We've seen quite a lot of aspirational calls, so there's a need for concrete examples. And some of us have been doing this bridging of implementation science and health equity in our work way before the pandemic and so on. So we wanted to sort of highlight concrete example of how we are synergizing health equity research and implementation science in our own work and provide those examples to the field, hopefully to help other people and other scholars think about this and begin to put this into practice. So yeah, Gabby, next slide. So we're not the first to call for emerging of health equity research and implementation of science. In fact, there's a lot of other people who've offered similar contributions in this area using similar terms. And Gabby has provided here, she did a great job actually. There's a whole thing in our paper of how many papers have actually looked at this and the different terminology. So there's a lot of discussion out there on this particular term. Today, we're going to define it from our approach and our view of understanding this, but it's one sort of approach of many people and scholars and groups who are doing this merging of health equity and implementation science. Next slide. Yeah.
Yeah, so with that, we were actually curious to get some numbers to figure out how much this was really being represented in the literature. So we actually did a PubMed search and we looked for the terms health equity and implementation science. And we asked it to give us articles that were really talking about both of them in the same article. And here's what we came up with. As you can see here, this really started happening more in the last decade with a really rapid increase in the last few years. What we also wanted to do was to layer on top of that some of the major events that we have seen happen in the field of implementation science as well as health equity. So what you can see here is that in 2001, there was the seminal Culture, Race, and Ethnicity report that was published, right? And then we see the NIH beginning to think about implementation science in the early 2000s. Then Unequal Treatment was published, and that really helped us think about health inequities. At the same time, the field of implementation science is moving forward with the publishing of the Implementation Science Journal. Then there's the first conference on D&I. And then the prestigious IRI program based out of WashU comes in 2010. Similarly, then in UCSF, the RISE cohort starts coming together in 2015. And so they are really specific in looking at the intersection of implementation science to address health equity issues. And then, as you know, in the last few years, we really saw the increase in sort of acknowledging the impact of systemic oppression, and really sort of our scholarship moved in the area of looking at health inequities. And a lot of people within implementation science started writing about how we can use implementation science to address these very issues. So we probably will see a continuing in the increase of these kind of publications across time. And this really sort of leads us to think about several reasons for why we want to argue for this merging of these fields that have often, operated in silos. And one is that even though there has been a lot of work to address health inequities, they are persisting, and arguably some of them are increasing, even though we've been doing really, really hard work in this area. The other thing is that we have recognized in our fields that we need to incorporate the voices of minoritized communities that are often underrepresented in our research. And even though there's been that recognition, they are still underrepresented in the research. So we have to find ways to bring them into the process, okay? The other thing is that until recently, this topic area of health equity has really been implicit but not explicit within the field of implementation science. So we really feel like there needs to be more effort to put that front and center. And to that end, not enough work, in our opinion, has gone to thinking about how to incorporate health equity into our implementation science work. Eliut?
Yeah, and one way to address that is by showing what we have done, right? So that people can see how that synergy occurs. And what we sort of thought about it in terms of how to make it operational, right? What we did was we brought together health equity research and implementation science elements. It's not one on the other, but it's sort of an integration of both. And the foundation is rooted um, in a more specific questions around health and healthcare delivery, right? How the thing that works can be accessed by those who need it the most, for example, or how can we sustain the thing in contexts in which resources are scarce. And so one of the things that we sort of looked in the literature is that the peripheral placing of equity, right? And we wanted to place equity at the center of our research. And so our argument is really that it should not be seen as a peripheral or a posteriori consideration or a special case, if you will, but rather it should be seen as a core component of the research that we conduct.
And so to help explain sort of what we did is a case study, and we looked at 3 different studies that we've conducted, identifying sort of our aims and things, and what was the health equity element, what was the implementation science element, and how do we bridge. So we'll talk about these 3 studies very briefly and provide sort of that understanding of what was the health equity element, what was the implementation science element, and how do we bridge them together. Yeah. So Gabby, I think, yeah, this is yours.
Yeah. Yeah. So to start with, I'll introduce my study and then I'll pass it on to Eliut here. So we are really focused in my lab on developing interventions for lots of different types of minoritized communities, but one in particular is immigrants and refugees from Latin America. And we co-designed an intervention called Cultivating Resilience, or in Spanish, Cultivando Fortaleza. And we sought out to examine the feasibility, acceptability, and preliminary clinical impact of this intervention through a pilot RCT, where we were testing the intervention versus a waitlist control with community dwelling Latinos. And what we did is we delivered this intervention across 4 different community sites, and we also had a virtual group, because part of what we were interested in too was answering the question, where could we embed this intervention? Where does it make sense for this intervention to be delivered in the community? And we enrolled 57 participants across those 5 different groups that we had. To talk a little bit about the health equity elements of this study, as I mentioned previously, we spent a couple of years actually co-designing the intervention with our community partners. And that was a very iterative process where we both were toggling between the evidence base in CBT interventions, but also approaching the community to hear about what were their priorities and how do we address that within this intervention. And we had, community engagement in really diverse ways, but throughout the whole process. And then when we were going out to test it, we really sought to embed it from the get-go in community settings, rather than waiting to get evidence and then taking it to the community. And in doing that, we were really thinking about ways in which we could increase access to participating. So we were thinking about providing childcare, thinking about transportation, putting it in community locales that were already trusted by the community, thinking about which partners could help us spread the word about this intervention. And then also, how did this intervention further move forward the mission of the different partners that we had? So how did it synergize with the work that they were doing? And so we collected information in terms of feasibility and acceptability. And we're really thinking not only about the impact of the intervention on the individuals, but also around how is it operating as we are implementing this for the different community agencies that we're working with. Eliut?
Yeah. So in our case, based in Puerto Rico, and we had been conducted for a long time research around culture and mental health and stigma. It's a huge barrier for people to access services, right? And so within that context, we focus on developing and pilot testing what we believe it's a fundamental cause of inequities, right? In a context, specifically in the patient-provider interactions, right? So the focus of this intervention was trying to address one of the gaps in the literature regarding the focus on developing and adapting stigma reduction interventions that only focus on changing the attitudes of people, right? And we said, that's an important piece, but when we as consumers and we as providers think about it, it's how you behave in the interaction, specifically what hampers people for continuing or even accessing the care, right? And so we said we need to focus more on the behavior piece of stigmatization process, right? And and so yeah, we co-develop really the intervention with key collaborators, um, focus on reducing stigma behaviors in patient-provider interactions and addressing it within a medical school context. And we just completed a study actually. We completed a randomized control trial in which we have, one arm was a sigma reduction intervention and another arm, the attention match control. And I think, yeah, the other slide, health equity. Well, the first is the focus on, I would say, on a key um, um, fundamental cause of inequity, which is stigma, right? I think that's a key element. The other piece of it is like I mentioned, we co-designed the intervention and tested the intervention with community engaged principles to ensure local fit, but also I think epistemic justice, right? There's no way that we can do this without the people that it's going to be delivered to. So the intervention also focused on a key health disparity population, right? Even though the intervention is developed for anyone, um, the focus of the training on how to engage in the interaction, it's around Latino mental health stigma and the cultural elements and pieces to it. And so we also address uh, different stigmatized conditions and identities, right? Also addressing intersectional stigma it's an important piece of that. So those are broadly the health equity elements. And the implementation science elements are really designing for the implementation from the beginning. We developed the intervention and tested it in the context in which it's supposed to be implemented, right? And sustain and maintain. And so I think that's an important piece. And the other piece is that we, of course, collected some implementation outcomes, right, through qualitative work at the beginning and at the end of the trial. Leo.
And yeah, and our third study is a peer-led group lifestyle intervention for people with serious mental illness. It's a hybrid one trial. We tested the effectiveness of the intervention versus usual care in 3 supportive housing agencies in the eastern part of the United States. These are for people with serious mental illness who are overweight and obese. And basically what we did was an effectiveness trials out in the community, and then we overlay in this RCT a mixed method longitudinal study to examine how this intervention was being implemented in these 3 supportive housing agencies, and examine that component. What was, and the next slide, what was the health equity elements from the very beginning were 3 fundamental things. One, we developed a steering committee from the very beginning to composed of the research team, the representatives from the 3 housing agencies. Our intervention was peer-led. These are peer specialists, people with serious mental illness who've recovered from serious mental illness are trained to deliver intervention. They were also part of our team, and they provided input into the development of our intervention, also how to conduct our study. we deliver the intervention. One of the things, and this is a common thing across all three studies, is that we were really thinking how to place this intervention, how to bring healthy lifestyle interventions to people's doorsteps. So take away all the access barriers and really bring the intervention where people live. So they don't have to go anywhere, the intervention comes to them. And in supportive housing agencies was a very good context for doing that. In terms of the implementation science elements, we collected implementation outcomes throughout acceptability and fidelity in particular. The overlay of that longitudinal mixed method approach to examine changes in context. When we do interventions in community, the mere fact that we are intervening in the community and studying them, we're changing the context already. So we really wanted to capture that and see how that context changed over time by our study and the intervention that we're doing. Actually, that was an important piece of information that helped us understand not only the implementation, but the outcomes of the intervention change depending on the context and the setting in which was delivered. And then we use qualitative data also to examine potential aspects of sustainability. At the end of the study, our community partners say, we would love to have information about how will sustain this once the R01 was over. So we actually collected information about sustainability and then developed sustainability plans for each of our study sites that the agencies can then begin to think about, okay, what elements of the intervention we can sustain beyond this research study. And those were our health equity and implementation science components. And so what we have done in this paper is really bring together all these case studies and begin to look at themes across the study. In the health equity research, you can see here, is the focus directly on reducing healthcare disparity. That was the heart of each of our study, that we are recruiting primarily minoritized communities, and we're focusing on those communities and examining those social drivers of health. We're applying different types of community engaged methods, and then all of our study emanate from a long-standing and deep and nuanced understanding of those inequities, bolstered by these studies being led by scholars from minoritized communities who have lived experience of these issues. So placing health equity at the heart of the study, not something as a special case or an afterthought, but really directly looking at that. And the implementation science side of things was designed for implementation, adopting to the social ecological system perspectives of our intervention, employing hybrid study design, so combination of mixed methods, hybrid designs where we're testing the intervention, but at the same time examining the implementation, and then really thinking through assembling a multidisciplinary team with all of this component, including people from the community as part of our teams. And then where these things come together is that we're situating the intervention and the research out in the community. Knowing the ivory tower, we're really bringing those interventions to the community and really thinking through how will this work in this community. The co-design element was really important for each of our study, thinking about cultural and linguistically and contextually relevant aspect of using participatory methods. And this co-design actually is not only about the intervention itself, but also thinking about the context of where we're going to intervene, that might also need some adaptation. So it's this mutual component of adapting intervention and the context to address that. And then each of our study weaves mixed methods and community engaged measures throughout to draw those community insights and wisdom and actually help us develop and improve our science in many ways as we're doing that. So that's sort of the heart and sort of the themes of each of our case studies, and hopefully provide examples of how we put that together. Next slide. Yeah. And I think you have this one, Gabby, right?
Yeah, so there's a couple of lingering thoughts that we had after we did this project. And the first is that a lot of our work here that we've presented is focusing heavily on hybrid type 1 studies, but we need more examples as a field of how do we do this in type 2 and type 3 studies. Our studies really focused on Latinos and Black and African American populations, and we need more examples of how these approaches might or might not work with other groups, right? There's probably a lot of things that we haven't considered that might be relevant for other groups. These studies really focused on adults, and so it'd be great to think about how do we begin to articulate what this could look like for studies that are working with children, with adolescents, and with families. Our studies, because we are in the mental health field, really did prioritize and focus on mental health, but we also need examples of what this could look like in other areas of health and healthcare inequities. And largely, a lot of our work was really prevention and promotion, and we need more research really focused on or more examples, I should say, of what this could look like in clinical interventions. So, with all that being said, we hope that you have found some of what we've talked about interesting and you want to learn more. We have a paper that is forthcoming on the topic, and hopefully, we'll get that out soon. It's called Equity Grounded Implementation Science Comparative Case Analysis of Three Studies, and we co-wrote it here. And one of the things that we did in that paper is that we included in supplementary materials a list of recommended readings of people who have already begun to articulate some of these ideas. So I'm just going to quickly move through these. But Alison has our slides, so if anybody wants this, she can send those forward.
We have
So we
already
are
gotten
really
requests.
you already got requests. Okay, yeah,
Yeah.
you can see we're really standing on the shoulders of giants here, and excited to be contributing to the literature in this way. So yeah, so with this, we will open the floor for any questions.
Thank you so much. That was wonderful. I love using a case study approach, and I also love that, I think the way that you set up your three studies really gives us a helpful rubric for thinking through, our own studies and how we might think about the different elements. Um, So it was just fantastic. And we do have some amazing questions in the chat already. So I'm going to turn to the first one that came in from Claire, where she noted that the equity elements seem to coalesce around inclusion. Can you talk more about how you differentiate equity from inclusion and diversity?
Hmm.
Great question.
Yeah.
Leo, you want to start
Yeah.
us off?
Oh, you threw me through the chart here. Thank you. No, so I think, I'm a little bit confused by the question about what do you mean by inclusion and diversity. Uh, for us, the equity in our study, the equity component, we had a clear inequity. People with serious mental illness are dying at a much younger age. If you're Black or Latino, it seems to be a double burden of disease, but because of the serious mental illness and the equity and the minoritized identity. So we're really addressing this health inequity of health issues. And to so that the heart of that was focusing on that and making a study where the majority of the participants came from Black or Latino population. In our literature, when we developed that study, there were very little studies that included Latinos or Blacks. And in fact, when we wrote that grant, there was only one study that had looked at a healthy lifetime intervention for Latino, included 6 people, right? So inclusion for us was important of like centering a study in that community and making the case of the importance. And we had to document that lack of research that we have because of a lack of inclusion and the diversity, and then making the case to the federal government saying like we're pushing all these interventions to increase the physical health of people with serious mental illness, but the literature that's being provided out there actually completely excluded Blacks and Latinos and other minoritized groups. The evidence might work, but we have no actual evidence of that. We need studies in that. So we were really putting that forward and had to make that case. And in fact, we had to like do a literature review, document the whole thing, and then provide that component. So, and to up today, there's some more studies in this area, but there's still this lack of inclusion. So I don't think there's an either or. I think it's sort of a combination of all the things: equity, inclusion, diversity. That's an important component here.
Claire just provided a follow-up. She said in the 3 studies, the equity elements seem to focus on inclusion of key stakeholders, but it feels different than the definition of equity. Is equity about who is being targeted with the intervention?
I see. Yeah. So equity does include that for sure, but also so thinking more broadly about not only the equity definitely of the problem that we are addressing, but we as a research team also thinking about how do we go about conducting our science. That's also the other piece here, that the science is to address equity, but also we're stepping back. How do we go about the approach that we take to develop our team, to develop our intervention, to run our study and our science, and bringing those for us community participatory approaches to help us understand, to help us bring. So equity has multiple levels here, not only on the topic area, but also how we practice our science, in a sense, another way that we have done that.
Yes, I'll say that I think that it definitely is about, increasing access to participating in these projects, so being more inclusive of voices that haven't always been there. But I think the other part of it is we're also really focused on characterizing the gap or the magnitude of the gap as well, right? What is that inequity? And then how do we reduce that through the work that we are doing as well, right? So I see some questions about measurement. There's also at some point got to be measurement about the magnitude of that gap, right?
And whether that gap is decreasing or increasing, or there's this assumption in science that what's the expression? Like the tide lifts all boats. Like if we do, equity requires us to think differently about different individuals and different groups. We can't just do the same thing and hopefully everyone will improve. That gap, actually, we need to do something different. Might need to adapt it to the population to address this gap as well.
I actually think that's a great segue to Ashley's questions about operationalizing the implementation outcomes. And this is something I was thinking a lot about as well. So, for example, how do you measure appropriateness from an equity grounded perspective? How do you integrate it with, integrate equity with your methods? Just maybe we can get into the measurement questions a little bit more, because I was also wondering, how might we think about equity as an implementation outcome, and are we in our more equity focused work able to articulate the extent to which we've maybe achieved the equity goals that we started with? How do we demonstrate that? Little combination of my questions and Ashley's questions. Hope that's okay, Ashley.
Sounds good. So I can start with the appropriateness, feasibility, and those type of outcomes. For in our study, what we wanted to make sure is that, first of all, can we recruit the individuals? Can we recruit people to this study, accept the randomization? And that's a critical component. And these studies also have a history behind them. How do we got here? We did a lot of community engage where we actually, this R01 comes from a photo voice project, where we examine what were the health needs of supportive housing agency, what would they want, what will be feasible, what type of intervention might be acceptable to that. So thinking very carefully of that data and how to inform our work. The other component is to have metrics. Part of the appropriateness feasibility is, can you deliver the intervention? Is it feasible to deliver and train peer specialists to deliver a very manualized healthy lifestyle intervention that would actually, we deliver the diabetes prevention program. So can we train, supervise, provide support for peer specialists to deliver that and provide them the supervision throughout? And thinking very carefully about that. We didn't have any attrition in peer specialists in our trial, which is something extremely rare with this population for multiple reasons. And part of it was, how do we engage them? How do we provide them good salaries to deliver the component? And how do we provide professional development options here? So that multiple level. From the intervention side, the measures of acceptability, do people show up? And then do people stay? And do they stay engaged? And we found great engagement in our intervention. And that has a lot to do with bringing the intervention to the community and also by the peer specialists and the engagement that they did. These are people with lived experiences with serious mental illness and obesity. And that experience really connected with people and made it salient for this. So it's figuring out those pieces and then capturing and measuring. I can talk more about other pieces for that, but for those outcomes, that's sort of what we did. And Gabi and yeah.
We did a couple of things to get at this idea of measuring acceptability and appropriateness. So once participants went through the intervention, after every session, we had a post-session survey and we asked them some questions about what they liked about the intervention or what the session, what they resonated with, what they did not like, and that was helpful. But we also did an exit interview with each participant. And our assessments were in people's houses. So we were in their space and talking with them about how this intervention was helpful or not, what they liked, what they didn't like, how they felt that really mapped onto their expectations for the workshop, what they got out of it, that sort of stuff. And then the other part is that one of my grad students is leading a mixed methods project where she's actually disseminating a national survey where we have gone through and described elements of the intervention through videos and through text, and we're asking for perceptions of appropriateness and acceptability and feasibility. And we embed in there questions related to dose and format and structure and content and things like that. So that's really helping us think about that. But then the last thing I'll mention is we have a community advisory board and we consult with them on a quarterly basis. And we are often bringing to them things that we're seeing out in the field, in the community, asking for their input, incorporating that, bringing that back to the community. So with all those different sources of input, that's really helping us be very attuned to the extent to which things that we're doing are appropriate or acceptable or feasible.
Yeah, it's very similar in terms of we do have a community advisory board. We have been working with community members and family members and physicians because our intervention also integrates physicians and medical students and all the work. And I'll say we did during the development, during the concept phase of the study, all the people were involved. During the implementation, they were all involved, and they are all involved in the maintenance of the intervention. Because I would say, beyond the traditional appropriateness, feasibility outcomes that we examine before and after the intervention, I'd say there's a key element, I would say, and it's about the belongingness of the people to the project, and that might be somewhat of an answer to the previous question about inclusion too. It's about people feel the intervention is theirs to work with, and they have adapted it. They're already implemented beyond, the scope of this project. It's already been implemented in the medical school, for example. The cases, I didn't mention this, but we measured our primary outcome using simulated patients. We wanted to see how people engage. They developed the cases. We intervene, right? But they develop the cases and they are already using it for other purposes, right? So this is something that it's theirs, right? And the sense of belonging, it's a bit beyond the inclusion piece, and I think it could be right something to measure for us in the field too.
Thank you so much. And you're getting a lot of compliments in the chat as well. And just a couple of things I wanted to pick up on. And you've touched on some of this in terms of your experiences with recruitment. And if there are any other comments that you have about recruitment, that would be great. And also just in terms of measurement, thinking about the measures that we often use were not necessarily designed for with people of color in mind, and any adaptations that maybe you've had to undertake with your measures or maybe in your qualitative work. But if you could speak to kind of making the measurement side of things more culturally relevant. And Leo, I know you have a long and strong history of doing that type of work. So are those topics that inspire any thoughts for you?
Yeah, no, as a equity scholar, no measures is developed, very few measures are developed for a community. So very early on, you have to learn how to adapt measure, how to select those measures, how to think very critically about whether this is the right measurement for this particular community, what changes might be needed. And that's why community engagement is so important, to bring those measures, to pilot it with your community group, with your steering committee. Not only on the type of measure, but language becomes really important. If you're doing this in multiple languages, making sure the translation is appropriate, is language equivalent to what you're trying to do. So I think it's really important. So the equity side of my brain, I was always thinking of that component, and really thinking through of the outcomes, that particular outcome measures and things like that. And qualitative work can help with that. Someone mentioned about recruitment as well. Recruitment, I always think of recruitment as an ongoing process, that it's not only about bringing people in, but then making sure people are staying in the intervention. So, for example, our intervention, we're delivering in the community, but there was this issue where these are closed groups. So what happened if someone misses a session? In the original intervention, there was no makeup sessions. That was something that to us was like, if you miss a session with your group, we will do everything possible to make that up, and have flexibility. And we work with the developers of the intervention to develop that flexibility. So it's like, you miss a group, no worries. We will bring it to you. You miss another group, no worries. We're here for you. So it's continuing to not give up on people as they're going through the intervention. And of course, that is something that you need to pay careful attention in science. But my implementation side of things, like, well, is that reality? Can we able to do that in the real world? So being careful on how we expand those parameters and things like that, and working with our agency. The other component of this is also bringing resources. Research, we take of research as taking resources out of the community. In these studies, we brought resources to the community, and thinking very carefully of how we can take an NIH grant or other grants and use that to create jobs for people, resources for the agencies, money, and funds to the agency. And that is also a very important piece that overlays sort of what we're trying to do, and thinking very carefully that research is a burden for many community agencies. So how can we facilitate that process and make sure that it's an investment that they can use? So, and we have multiple strategies on how to do that. Universities are awful at doing this. I'm being recorded, I don't care. So really working with your university on how do you make those subcontracts available, make sure that those resources are really being used correctly, and that the money is going out to the community, not so much for the universities. Yeah.
Mm-hmm. Yeah, I just wanted to add a note on recruit. We do a lot of things similar to what Leo described in our study, so I won't sort of say all that because that's redundant. But what I will say is that recruitment for us was a really, really important part of our study. We hired someone from the community as our study coordinator, and that person grew up in the community, spoke Spanish as a native Spanish speaker, which she was bilingual. And she was knowledgeable about the lab, the research that we were doing. She understood, at a basic level, what it is that we were trying to do with her community. And she could communicate that in a way to people from her community that made it relatable, made it understandable. It also was a process that took time, her investment. So we would go to community events, and whoever was interested would give us their name. She would follow up with a phone call, and she might have multiple phone call conversations at times that were appropriate for them, and really talk them through, this is what it means. What concerns do you have? How can I explain this in a way that makes you feel more comfortable? And that really led to some really high engagement over time because we were developing really authentic relationships with our participants. The other thing that we did is we also sent a quarterly newsletter to everyone in our study, and we kept them in the loop about this is what's happening. We have another group, and here's what we've done, and here's some preliminary results, and stay tuned for more. And that really over time began to create this sort of community momentum around interventions that could really support immigrant health.
In my case, it was a bit different because it was a medical school. And so during the development phase, we heard from the people that we wanted to deliver the intervention to, you need to try to include the intervention within our convoluted schedule. And so having them from the beginning was what really allowed us to actually do that, which worked in the end, right? Because that's how we got people into the study. So just wanted to add that a bit different perspective.
Thank you. And your responses touched on several other questions. And again, you're getting lots of compliments in the chat for your work. One that's come up, a question that's come up that I don't think we've touched on really yet, from Jennifer, is around, equity often being framed as an add-on to the focus of our work, and then it's difficult to convince funders of its importance and the value of doing it right, which means doing it slowly and methodically, as you all have described. Can you speak to how you've navigated these types of challenges on the funder side?
Yeah, I would say perseverance and never giving up, because all of us have grants that were not funded, and so here's where the health equity component comes in, at least, and I can speak to how we frame our things. We have to document those inequities to funders and really highlight for them why this study is needed. So as I mentioned, when I was writing that R01, we did a systematic review of healthy lifetime interventions of people with serious mental illness for the past 25 years. And we could document how many studies, RCTs, or intervention study, actually included minoritized group, and presented that data in our grant to the funders, saying, hey, you're moving this forward. This is a major area of research, and here's the data of the lack of research in this area. So documenting that component becomes really important. The other part is being, part of, and I'm talking NIH component, innovation. The innovation and highlighting, look, this is innovative. It's innovative to bring a health equity component and implementation science and blend it. And here's sort of how we're doing and why is this innovative to the field, to the gap that we're trying to address, and making that case, and then hammering that constantly to the other component is the partnership that you're developing. So having the right agencies and having their support in moving this forward. This idea of this, for us, this idea actually came from the community. This supportive housing agency came to us with a particular problem that they had. And then we put our heads together and say, okay, how do we address this health inequity in supportive housing? What would that be? And then build it together. One thing that we don't do much in our field is actually talk about the trajectory of projects. We hear about the R01s and the N and the R34, but how did we get there? What are the series of studies that got there? And that actually is really important because it lays the foundation for what we're trying to do, how to make that case, how to address the long-term engagement that we will have with these communities, and then how these pieces fit together. So I think that's another component. Lastly is being outspoken about this for funders, like your program officer, sending them your papers, sending them the information, being open to discuss these issues in different options. So really trying to make the case for the work that you're trying to do, and then perseverance. I mean, it's hard to say, but it's like you have to stick to your guns on this and follow through throughout. So.
One suggestion I have too is saying in your grant, like this project aligns with this specific NIH priority, and just putting that so clear to say how it actually is so aligned with what they're trying to do, or what at least they say that they're trying to do, right?
And that also, just linking that to what Leo was mentioning, it's about long-term thinking. And I don't think we're used to that. Mm-hmm. I think the way everything is built is very short term. Even, talking about 5-year span, this is a long-term thinking that you really need to engage with community, with program officers, and all that line of research, right? So I think that's a key component.
I know we're rapidly moving to the top of the hour. There is a question that I was just reminded of because you mentioned sustainability, and Evan was asking about the sustainability of equity-grounded implementation science projects, and whether you can think of any examples, or are we not at the longitudinal point yet of being able to see, you mentioned, Leo, the trajectory of projects, and are we at a point where we can look at sustainability of these types of projects yet, or are we still working toward that?
I think we're still definitely working towards that, Alison. But sustainability is something like we actually did not write that in the grant. We did not have an aim about sustainability, but this came from the community and from our steering board. At the end, we were doing this longitudinal qualitative study, so we had a chance at the end of the trial in year 4 and 5 to interview the organizations. And when we were thinking about that, we asked, what would you want us to ask? We have our ideas. And sustainability was one of the things that came out. So then, as implementation scientists, okay, how do we study sustainability? And we use a measure, and I'm blanking on the name of the measure, but it's like the sustainability of programs. It's from Doug Luke's work here at WashU. He has a survey of planning for sustainability, and we use that with qualitative data, and that's how we develop the plan. So I think that sustainability is something to consider. All of us are designing for implementation. That also considers sustainability, making sure that the intervention is something that can be used and can be in the community. But we need more studies on this. We rarely have studies where you have an R1, an intervention, and then we come back 5 years later and say, hey, where's this intervention? What are the outcomes? How have this intervention been sustained? I only, in the area of research that I know of only one study that's doing this. This is Kelly Ashburner from Dartmouth, another group there, and Steve Bartell from Harvard. They are actually examining a sustainability of a exercise intervention for people with serious mental illness on a massive R1 that they did national, and now they're going back and seeing how sustainable that is. So I think there's a case for doing that type of work, and it's so important, and funders should support that work to see the investment of their science into the community. Yeah.
Right, that's one of the challenges is to convince funders that you would want to kind of study what happens in the sustainability period. We tried to make a case for that in
Yeah.
one of our equity-oriented projects a while ago. So we have just a couple minutes left, and you touched, Leo, on the organizations coming to you and requesting the work. And I wonder if there's anything else that any of you want to share about engaging the community organization partners, approaching them, getting their buy-in. Anything else you want to just touch on briefly related to that?
Yeah, I feel like we had some wins, and then we also had a piece of humble pie in really sort of engaging in this process, I'll say. So I switched institutions a couple of years ago when we were getting ready to launch the intervention. So I had done a lot of the formative work in North Carolina when I was at Duke, and then moved to Wisconsin a couple of years ago. And we had co-designed that intervention with our community partners in North Carolina, but then we were here in Wisconsin reaching out to new organizations after the thing had been developed. And so sometimes, there were community partners who were really excited about it, and the response was, oh, this is great, like, let's do it. And then some other folks were like, wait a minute, like, we were not involved at all in that process. So how do we even know that that's relevant for our community? And so that was a really interesting process where we had to really sort of negotiate and really work with each of those individual partners concurrently, but we also had a timeline for our project that needed to happen in this particular way. And so that was very, very complex. So, trust, we learned, was really hard to build and very easy to break in the long term.
Great, thank you. And I see there's interest in publications on the intervention components, so I'm hoping that that is probably in your forthcoming paper, I'm guessing, to some extent. And then Heather posed a question which we probably do not have enough time to grapple with, in our remaining 4 minutes, but just asking about the role of allies and decentering whiteness. having the responsibility for those of us who are not people of color to work against, these persistent discriminatory structures. How do we kind of what space and place do you see for those of us who are engaged in this work and, very, very much responsible for the changes that need to happen?
Yeah, that's a very complex question, but I must and definitely we don't have the answer in today in 3 minutes. But I do want to sort of highlight that there's a lot of work being done on equity that is not from minoritized groups, that it's actually from non-Hispanic whites that are doing some of the work that I do and the approach that I take on community-based participatory research and what I learned it from a white guy at UCLA, actually, from Ken Wells and his team and his work on CVPR, and not only about sort of the study that he was doing, but how he set up his science, how he set up his teams, how he actually think about participatory approaches, the values and the mission that he brought to that was very important. And it's actually respecting the community, bringing people in, providing resources, and honoring the wisdom that the community brings. So it's really bridging this world and creating true partnerships between that. And that's a long process and complex one. But it is possible to do with respect and understanding, deep understanding of the community itself that he's also entering. So yeah.
Yeah, that's a very difficult one to answer, but I would just say briefly, I think this relinquishing power. I think if you have to summer that up, that would be it. And there's a great paper by Let, I think, I can't remember the year, in which they trace a phases for doing that. So I can send the reference if it's of interest.
Yeah.
Great. Maybe we can add it to the slides and then we'll send them out. You all were very generous in making the slides available, so we can add that. And if there's anything else, we can maybe put in a reference for the PSAT, and anything else that comes up, we can make sure to get out to everyone. So I want to thank you so much for doing this today. I learned a lot, as I knew I would, from the amazing work that the three of you are doing. We're so excited to see the paper, and thank you for giving us a wonderful glimpse into what this paper is going to offer and to the work that you're doing in this space. It really is so exciting to see that operationalization of things that we have been reading about more in principle, and seeing how you're doing this and how you're working through the many issues that come up has just been very, very exciting and illuminating. So thank you so much. Thank you to our audience. Please come back for future Beachside Chats, and we really appreciate everyone's engagement and excitement about this topic. Thank you so much, everyone. Have a great rest of your day.
Gracias.
Take care.
Thank you.
Thank you.
Bye.
Thanks.
Bye.